Samizan. So let's start from Samizan. So you are the examiner and Amir is the candidate.
ठीक है. Okay, Amir. There is a 32-year-old male brought to emergency with history of RTA, and on arrival, his pulse is 116 per minute, and blood pressure is 80 by 60 millimeters of mercury. Respiratory rate is 26 per minute. So, how will you approach this patient? What will you do?
Sir, can you please repeat the scenario?
Yes,
There
please.
was distortion in the voice.
Okay, a 32-year-old male brought to the mercury, and respiratory rate is 26 per minute. आवाज आई?
Blood pressure 60 and what else?
Respiratory rate 26 per minute.
So on receiving the intimation, I would activate the trauma team and I would assign different roles to my team members, uh, like airway, breathing, and circulation, simultaneous assessment and management. I would gain maximum information from the EMS staff about the mechanism of injury and all the treatment provided. This patient is in shock and is respiratory distress. I would rule out, I would start from airway and I would assess and maintain airway, keeping in view the inline cervical spine stabilization. Uh, I would assess his breathing. I would see whether the trachea is central or not. I would auscultate on both sides and palpate on both sides for any evidence of crepitus or rib fractures. I would
Okay, on auscultation, the right side has got diminished breath sounds.
so then I would like to percuss. What are the findings on percussion on right side? Is it dull or hyperresonant?
It's hyperresonant.
So this patient is having obstructive shock secondary to right-sided pneumothorax. I would decompress his right hemithorax with needle thoracostomy followed by finger and tube thoracostomy on the right side. Thereafter, I would reassess the patient and I would like to see is he comfortable
So,
with the breathing? Has the
so
respiratory distress improved or
with
not?
this
And
with this maneuver, his respiration has slightly improved, and his sats have improved, and he is breathing comfortably. But his blood pressure is the same, 80 by 60 millimeters of mercury still.
so I would reassess and I would maintain circulation. By now, two large bore IV cannulas have already been placed and by my team members, and samples have been taken. I would attach warm fluids and
Sorry, the before this, the chest tube has about 1000 milliliter of blood once you put it in. So any management for that or anything?
so that is a significant amount of chest hemothorax. Uh, However, keeping in view the present BP of the patient 80 by 60, it there is some other cause that needs to be found out in this patient. I would look for any evidence of cardiac tamponade, hemoperitoneum, hemopelvis, or any long bone fracture leading to
So what would
excessive
you do?
bleeding.
How would you assess?
I would assess by uh, physical examination uh, and also by doing fast and chest x-ray and x-ray of the pelvis.
Okay. So once you did the fast, there was moderate fluid in the abdominal cavity.
That confirms my suspicion that this patient is not only bleeding in the right hemithorax but also in the abdomen. So this patient is unstable patient. I would ask laboratory to release, hematologist to release blood. I would inform OR
Which blood would you
for
ask for?
preparation.
What kind of blood would you ask for?
In this patient, I would go for uncrossed matched blood because there is no time for
You mean RCC, red cell concentrate, right?
RCC. Yes, RCC plus if packed cell volume are available, or otherwise RCC, platelets, and FFPs in ratio of 1:1.
Okay. Then
Then I would inform OR and I would prepare this patient for laparotomy in order to stop the ongoing bleeding inside the abdomen.
okay. So can you tell me how will you approach the laparotomy?
I would after performing WHO checklist, I would in the warm room, I would expose the patient from chin to mid thigh, and I would place him in supine position, and I would start with the generous midline approach, and then I would systemically examine, pack and examine the whole abdominal cavity, looking for any evidence of injury, and I would try to identify the bleeding site.
Okay, you found more blood in the left hypochondrium.
So that then I would be most probably suspecting a splenic injury. I would look for splenic injury in this case, and I would like to see that whether the spleen is what's the grade of the injury. I would assess, and then I would manage accordingly.
It is shattered, ruptured.
So this shattered spleen in unstable patient is an indication for splenectomy. I would
Can you please
with
tell me
my
the steps in this case?
I would with my left hand I would dissect phrenico-splenic ligament, and I would mobilize the spleen and pull it in medially into the wound. Then I would place a clamp on the pedicle, splenic pedicle, and later on I would divide all other attachments and remove the spleen. I would
Okay.
double ligate the pedicle to prevent
Okay. After the
bleeding.
splenectomy, what would you do?
I would continue my resuscitation efforts, and I would shift the patient to high dependency unit for
No, in the
monitoring and
during the surgery,
resuscitation.
there's nothing else that you would like to do?
Per op, I would examine all the abdomen for any evidence of associated injury, any hollow viscous injury, or any other solid organ injury.
All right. Thank you. In the same scenario, I would like to track you back to the chest trauma. Once you put in the chest tube, let's suppose that there was 1500 ml of blood that initially came out in the chest bottle. Now, how would your approach to this patient change, or would it change or not?
Yes, it will change because it's hemothorax, massive hemothorax with hypotensive patient. So it can be the cause of hypertension of the patient. In this case, I would involve chest surgeon, and I would go for right anterior lateral thoracotomy, and I would clamp the aorta. That would control both intra-abdominal and chest bleeding. Moreover, I would identify the site of the bleeding from hilar pulmonary or intercostal vessels.
So you would wait for the thoracic surgeon for this surgery?
If he is around, then I will wait. Otherwise, the patient is in shock. I would not wait. I would proceed with thoracotomy, and the thoracic surgeon can then join later on.
And what, in your opinion, is the cause of this massive bleed?
It's both thoracic trauma as well as splenic trauma in this case. So this patient has
the thoracic bleed. What do you think that is the cause of this bleed in this patient?
most probably, most commonly, it occurs from intercostal vessels, pulmonary hilar vessels, uh, and intercostal internal mammary arteries, and some systemic vessels like great vessels like aorta.
Okay, thank you so much. So this was the first scenario. Bhai log.
Thank you. Thank you, Siddharth.
Okay, the
कि
next.
हमें तूने ब्लड
I
ब्लड क्रॉस
asked
मैच
one
वगैरह का
question.
जिक्र नहीं किया कोई
Okay.
Yes,
I
sir.
would like to ask one question from Hamid.
Sir.
So by performing the right anterolateral thoracotomy, you mentioned about the clamping the aorta. How will you clamp the aorta from the right side?
Sir, I would go at the supradiaphragmatic area, and there I would dissect, and I would.
So on the right side, there's the inferior vena cava.
So the aorta is just beside the vena cava.
Beside
We can
the vena.
approach it. Yeah.
Now, in this case, for example, you have to do the right anterolateral thoracotomy. Most of the time, the bleed is, as you have already mentioned, it's most likely from the intercostal vessels, the internal mammary artery. Most of the time, it's from the lacerated, it's a lung laceration, which is actually bleeding. If it's massive, so then you have to rotate the lung on its pedicle. So if it's coming from the pulmonary veins, if it's coming from the high lung, you need to rotate the whole lung. So for that matter, you need to divide the pulmonary ligament. So you cannot clamp the aorta from the right side. It's on the left side. If you have to do the aortic clamps, you have to do either you have to
Do a clamp.
yeah. So one more
हाँ जी,
suggestion.
आंटी,
Once Samizan asked, you gave you the scenario. There's a patient has slightly improved. I think if you can ask them, okay, what is the output from the chest? I have placed in the chest. Yes, the saturation has improved.
yes.
So what is the
It should have
output?
been asked by you. It should have been asked by you. Okay, I put in the drain. So can you tell me if there is any blood in the drain?
Yeah. So then
Because we just skipped that part. You put in the chest, you did the needle thoracostomy, then you put in the chest tube, and then you moved on to find out the other causes, right? You went to the abdomen and all.
okay, similarly, so once your plan was to do the laparotomy, so you have shifted the patient the laparotomy. We mentioned it earlier yesterday as well. So you need to mention that I will prepare the things. For example, you need the suction is ready, the blood is available, the thoracotomy set is available before making the incision. Your vascular set is available because this is the patient who may require the thoracotomy as well, and he may require because the patient the hypotension. You may have to clamp the aorta, so you don't know what are the actual injuries. So we need to mention all those things unless they are interrupted by the examiner.
वो भी बात करनी चाहिए.
Okay. Any other things, sir? From
Blood की तो हमने बात कर ली थी कि जी I would arrange blood, uncross
yeah,
match blood जो है.
yeah. So anyone else?
Yes, one thing more. Initially, once you put in the chest tube and then you went on to circulation, at that time you did mention this two IV bore cannulas and fluid bolus. But once I went back to telling you about the blood in the chest bottle, you did not afterwards again reiterate your point of giving the IV bolus and the fluids and all. So I would have liked it more if you had said that. Okay. And one thing more in the, sorry,
Yeah. So
please.
but one more thing is you need to ask them what are the now after giving the fluids, bloods, now what is the current condition? So that means you are reassessing the patient condition. Might be after giving the fluids and blood, the patient condition has improved. So that changes your management plan.
I should have told you actually. I should have told you that now that his blood pressure is this, pulse is this. I'm sorry if I missed that, but otherwise you can always ask.
Yeah.
So is there any change in the vitals by this procedure, by this maneuver? Is there any change in the vitals as the patient improved or not? One thing more, once you asked about the thoracotomy, I would have liked to hear the word of emergency room ER thoracotomy, because this becomes a case of ER thoracotomy with 1500 ml of blood in the chest drain right away. So if you keep on waiting for the thoracic surgeon, yes, it's a good thing that you sent a call for the thoracic surgeon if available with you. But if not, then you should right away move to the next step and perform the ER thoracotomy.
No,
Uh,
sir, this is not actually ER thoracotomy. This is emergency thoracotomy.
Okay, emergency thoracotomy.
Emergency thoracotomy.
Yes, emergency thoracotomy. Good enough.
And yeah, this emergency thoracotomy, once it's done in the OR, it has better outcomes than
Yeah.
done in the ER thoracotomy. So that's why they say that you take the patient to OR
To
if
the OR. Okay.
he requires thoracotomy.
Okay. Good enough.
Amir,
Anything
it was
else?
a well responded, answers by you. And would you like to do anything? You have performed splenectomy, you have performed thoracotomy before discharge. Would you like to do anything for the patient?
Sir, in this case, this patient is on high risk of OPSI. So I would perform vaccination for meningovax, Hib, pneumococcal vaccination for this patient.
Meningococcal, pneumococcal, and
Pneumococcal and Haemophilus influenza.
Okay. So,
So,
That would be before the discharge.
Shafaqat,
okay, Samizan.
no sound. आवाज नहीं आई.
नहीं, okay. I am asking if Usman or Sulaiman, if you want to say something.
सर शफाकत आवाज नहीं आ रही.
आवाज नहीं आ रही.
थोड़ा लागे हो क्या सर बोलो.
Yeah. अच्छा, can you hear me? Can you hear me?
Yes.
Shoya. Okay.
From
So
distance, sir.
okay. Let's move to the next scenario. Samizan.
Yes.
Okay.
Yes.
The next scenario again, Amir, I would like to begin. Just a minute. Yes, please. 28-year-old male has reported to the emergency room with a sudden onset pain abdomen for 6 hours duration. And he also has had one episode of hematemesis. How would you approach this patient?
Well, this is a young patient with hematemesis and pain abdomen. I would like to know where exactly he is feeling pain in the abdomen. Is it upper abdomen?
Upper abdomen.
Upper central abdomen?
Upper generalized abdomen. Generalized upper abdomen. Right side, both right side, left side, and central abdomen.
So in this case, I would be concerned about my most probable diagnosis would be peptic ulcer disease, esophagitis, gastroesophageal reflux disease with severe esophagitis. I would also like to rule out malignancy, gastritis.
So you want to say that you would like to start off from history, knowing if any previous such condition is there in this patient.
The risk factors, and then in this case, these are the likely possibilities, and I would explore them with history and followed by examination. And then I would like to know.
On examination, his pulse is 110 per minute, and his blood pressure is 100 by 60 millimeters of mercury.
So this patient might have a massive hemoptysis, because of which he is hypotensive now, or he might have some other associated problem. I would like to know what are the findings on abdominal examination in this case.
Abdomen is generalized tender, but more tenderness in the upper abdomen.
So in this case, I would go for an erect X-ray, chest, serum amylase, lipase, CBC, and ultrasound of the abdomen.
All right. So you would not like to give him any IV fluids, bolus, IV
Yes, this
access
would be a,
before this?
yes, this would be. At the same time, I would continue my resuscitation since he is hypotensive. I would put in an NG tube. I would give him IV fluids, antibiotics, and I would like to see whether he is taking any anticoagulants or not, or any. Does he have any
Hello, Assalamu
disease
Okay, before
predisposing to hemoptysis?
before
Yes.
getting an X-ray abdomen done, Shafaqat, can you please pause? अच्छा चलें continue करें फिर. So before going for the X-ray, the patient suddenly vomits, and it's a hematomasis, massive hematomasis, and he becomes and his pulse is now 116 per minute, and his blood pressure is 90/60. So what would you do
I
now?
would send all the samples for the baselines, including typing and cross matching of the blood. I would inform laboratory to release blood because this patient is losing blood and he would require blood transfusion because resuscitation of blood is with blood. So at the same time, I would continue. I would try to find out the cause and.
What is the most likely cause in your opinion in this case?
I would like to know that whether the patient has some stigmata of liver disease or not.
No.
Because such massive hemoptysis is generally the feature of gastroesophageal
No liver
varices.
disease known before.
So the second possibility would be a bleeding peptic ulcer that bleed massively, or some tumor.
So how would you like to manage that?
I would, while continuing my resuscitation, I would request for an urgent endoscopy in this case.
Okay. So urgent endoscopy was done, and they found a bleeder, but they could not negotiate it endoscopically.
This patient
In
is
the first part of
hypotensive.
duodenum.
He is bleeding, and he requires control of the bleeding site. Again, I would, in this case, I would inform OR. I would tell a laboratory to release blood. While continuing my resuscitation, I would take the patient to OR, and I would perform a laparotomy.
Okay.
And I would oversee the site of the bleeding by performing gastrotomy.
By performing?
Gastrotomy.
Gastrotomy, okay. And what will you do to the ulcer? Anything?
I would take
How will you
biopsy.
manage
If
that?
it is a gastric ulcer, then I would take biopsy. I would like to know exactly where endoscopist identified the ulcer.
Okay, it was in the first part of duodenum.
First part of the duodenum. Then I would not take biopsy. I would just oversee the bleeding vessels at 3 points, and I would secure hemostasis, and then I would close transversely.
Okay. Thank you. जी भाई
Should I continue?
जी please.
Starting with Amir, we will talk about the suggestion. Later on, we will give you the positive assessment. Can you hear me?
शफाकत तेरी आवाज नहीं आ रही.
Shoya.
Shoya. Okay, I don't know what the problem. Okay, so Amir, so once you were given the scenario, during the history, you can ask a few more questions, starting from there. So that will help you clarify your situation. Similarly, what the examination findings, one of the important findings that was shared by the examiner was there's a generalized tenderness. You need to ask while performing the laparotomy and chest X-ray, you need to ask what are the findings? Is there any air under the diaphragm or not? So once you have opened up, so I think there is there's anterior perforation and the bleeding peptic ulcer as well, because the finding was shaped generalized tenderness, but more in the upper abdomen. So once you have opened up the abdomen, to just ask, so what are is there any contamination? Is there any, I would like to see whether there's a perforated dudenal ulcer, interior perforated dudenal ulcer as well. So you need to take care of that, that as well.
Generally, the bleed, generally the
भी टेंडरनेस कॉज कर सकता है।
बिल्कुल
एयर
कर
अंडर
सकता है।
डायफ्राम जो है ना, वो सर ने नहीं बताई।
नहीं, you need to ask.
मैंने आपको एक्सरे कराने ही नहीं दिया ना। I didn't let you go to the
उन्होंने
X-ray.
कराने नहीं दिया. No, he has not. So then you can एक दोनों hint दिया ना, he has given you the finding. There is a generalized tenderness, or in the epigastrium, there's a generalized tenderness. That's why you ask for the amylase and the lipase. So then later on, gave you the scenario. There's a massive bleeding, and just forgot about the generalized tenderness. So once you have opened up.
Had you not told me about the chest X-ray, then I would have asked you that what one investigation would you like to do in this patient.
Yeah.
To give you, and once the chest X-ray is done, there is gas under the diaphragm, so diagnosis is almost certain. So after that, you move on to the management then. So I just skipped that and just wanted to see whether you involve the gastroenterologist or right away move for the surgery.
Yeah.
So involving the gastroenterologist was the correct thing. Then most of the times they can negotiate the bleeding vessel endoscopically. But if they are not able to, then there is a place for us, the surgeons, to go in and manage it the way you did.
Okay, one more question you can ask from the examiner. Once he gave you the finding of the examiner, he gave you the pulse and the blood pressure. Ask about the conscious level. Is the patient conscious? Is the patient having any signs of the shock? For example, is there any cool, clammy peripheries? So you can ask this question from the examiner.
सर वो तो जितने आप अपने लिए कुएं खोदते जाएंगे वो कहता जाएगा ठीक है।
No. That will help you, because if the patient, if he says the patient is conscious, there is no evidence of any cold, clammy periphery, that means patient is much in stable condition. If he says no, the patient.
He is right. Shafaqat is right in the sense, Amir, I have written down in my scenario that initially the patient was stable vitally. Okay. But later on, after the second episode of hematemesis, he became unstable. So it is pertinent to ask if you can.
I would like to ask.
आमिर इसमें कोई राइजक वगैरह का
consciousness level and urine output, ठीक है, ये भी है। Yes sir, please.
मैंने कहा इसमें कोई राइजक और पेन किलर का तूने जिक्र नहीं किया उसका पेशेंट को।
हाँ, ऑक्ट्रियोटाइड और उसका पीपीआई, आईवी पीपीआई बोला उसका देना।
पीपीआई दे और पेन किलर तो देना, पेन में है पेशेंट तो।
बिल्कुल सही है, हाँ
ठीक है।
एनाल्जेसिक्स, पैरासिटामोल दे देना।
फोली वगैरह साथ ही, फोली और एनजी साथ ही डलवा दें।
एनजी फोली बिल्कुल सही है। एनजी से जो है वो पता भी चल जाता है कि स्टमक से ब्लीड है कि नहीं है। एनजी फोली।
यस। सो अच्छा, ठीक है, ओके, गुड इनफ। बस मेरे ये दो ही सिनेरियोस थे यार आज की, जो मैंने वो भी थोड़ी देर पहले ही देखे थे। सो एनीवन एल्स प्लीज।
वाकई तेरी आवाज में कोई मसला है
यार सर, पता नहीं फिर क्या हुआ है इसको। पहले तो बिल्कुल ठीक था। हाँ,
अब ठीक
दरमियान में गायब हो जाती है
ये। आई डोंट नो,
तुसी उदा ही बोल दे जो है भाभी अगे बोल दे हो।
और नहीं, अब मेरी बात सुन, ये फिर मैं इसको पॉज कर ले इसको, ठीक। ओके,
नहीं सर शफाकत, इसका मुझे जरा बात करने दें आमिर से। आमिर, अच्छा, is there any other option instead of surgery for managing bleeding peptic ulcer?
Yes, we can go for angioembolization. If the facility is available, then angioembolization is an option.
Okay, and for how long patient should be offered PPI after surgery?
For such bleeding and perforated ulcers nowadays, recommendation is to offer lifelong PPIs.
And will you do anything else, any other investigation or any other therapy?
H. pylori eradication therapy will also be done.
And how it is given?
So basically, at the once endoscopy is done, biopsy is taken, and there in the biopsy specimen, H. pylori infection is identified. Then we give omeprazole, clarithromycin, and amoxicillin. This combination for 14 days, and then omeprazole is continued for additional 8 to 12 weeks.
Okay, fine. Thank you.
H. pylori, H. pylori हर केस में देना है perforated DU में या नहीं?
जिसमें H. pylori की इन्फेक्शन आएगी जब ये बायोप्सी करेंगे इसमें
अगर हम perforated DU ऑपरेट करते हैं तो पोस्ट ऑप हमने H. pylori हर किसी में देनी है या नहीं?
नहीं सर, जिसमें एविडेंस है, बगैर एविडेंस से कुछ नहीं करना, एविडेंस बेस्ड मेडिसिन है.
So in case of the perforation, dudenal perforation, so it's a routine, we don't take any biopsy. So then how the eradication will depend. It's on, if it is a gastric ulcer, yes, we take the biopsy and send it, you can send this person for H. pylori in addition to histopath.
Is there any other investigation you can do?
सर वो हम जो बायोप्सी की बात कर रहे हैं, that is histopath. This biopsy is a small mucosal biopsy just to identify H. pylori infection. That is taken in cases of duodenal ulcer.
You will do endoscopy to take biopsy.
Yes, if the patient is not amenable to surgery, then we'll go for endoscopic biopsy. But if we are if we open him up, then we take biopsy at laparoscopy.
Okay, Amir, I'm still confused. So if there's a perforation, so you mean we need to take some biopsy? We need to enlarge the perforation so that we can send it for the H. pylori and the histopath?
No. In gastric ulcer, we take the biopsy in order to rule out malignancy.
Right.
That is a separate.
But in case of duodenal ulcer?
In duodenal ulcer, it's endoscopic biopsy or it's a per-op biopsy just to identify the infection of H. pylori.
How, if there's a perforated duodenal ulcer, how will we take the biopsy?
Sir, since we did endoscopy pre-op, we'll take biopsy at endoscopy.
I think this per-op biopsy is not indicated, Amir, in this case.
Yes.
If you are concerned about going by evidence, you can do his serology for H. pylori or stool.
Since we are discussing a case which I asked.
ये जो H. pylori test है ना, ये तो fecal antigen test है. If somebody has got infection ever with H. pylori, that would be positive. अब इसकी जो active infection है ना, उसके दो, एक तो ये है कि urease breath test है. Urease breath test आप कर सकते हैं. दूसरा gold standard ये है कि ये mucosal biopsies हैं. Mucosal biopsy जब आप endoscopy कर लेते हैं तो उस पे फिर आप ले लेते हैं. ये है in symptomatic patient, gastroscopy with biopsies is preferred test for diagnosing H. pylori infection as it allows the characterize the gastric mucosal pattern and pathology examination will identify gram-negative bacilli resistant to acid pH.
Amir, you are right, but we are talking about the perforation scenario, emergency scenario. If the patient has presented with a duodenal perforation.
तो इसमें जवाब क्या है? असल जवाब बताना शवाकत, असल जवाब बताओ.
मेरा duodenal perforation is clear cut. We do not. Biopsy is not a recommended. Biopsy नहीं, biopsy लेंगे तो आप.
नहीं सर, इसमें आप दो चीजों को you are confusing two things. There is जो हम biopsy लेते हैं ना per op, that is histopath in cases of gastric ulcer that we take in order to rule out malignancy, because gastric ulcers, they have high chances of malignancy, but there are little chances of malignancy in cases of duodenal ulcer. That's why we do not take biopsy.
Yes.
That is what we are talking about, refreshing the edges and the marginal biopsy. that is the biopsy from the margin of the ulcer. It's the biopsy from site of inflammation or site of erosions, और उसमें जो है it's not necessarily जहाँ जहाँ पे भी गैस्ट्राइटिस का पैच है या ड्यूडेनाइटिस का पैच है वहां से आप छोटा सा वो पीस ले लेते हैं and then
But that can be done by endoscopy, Amir. How can you
right
do
now
it?
we are discussing the perforation. Perforated
We are
dudenal.
discussing the per-op scenario of
Perforation.
perforated dudenal
It's
ulcer.
not the pre-op. The patient has
Yes.
presented with a dyspepsia. So that is another scenario, separate scenario. In that case, yes, we take the biopsy and we can take the mucosal.
The septic ulcer. अच्छा, let me please थोड़ा सी मैं बात करूं because I had this scenario made. So I had written with me that the cause of ulcer in this case was
NSAID.
NSAIDs, yes, NSAIDs.
Yeah.
ठीक है, so H pylori वाली डिस्कशन जो है ना वो यहाँ पे नहीं होती, and especially मैंने लिखा हुआ था but हिस्ट्री में ये उस तरह से चीज ना मुझसे पूछी, the history of NSAID intake. तो if Amir had asked, I would have
मैंने
told him.
ड्रग्स का सर जिक्र किया है,
हाँ,
लेकिन
जिक्र किया था बट वो उस तरह से को क्लैरिटी नहीं आई हम लोगों को ना. तो इस केस में द कॉज वाज नॉट एच पाइलोराई. एच पाइलोराई वाला सिनेरियो एक और है, वो डिफरेंट है, वो विल आस्क सम अदर डे और सम अदर टाइम. उसकी क्योंकि उसमें भी उसका प्रोटोकॉल थोड़ा सा वो डिफरेंट भी है. खैर एनीवेज माय पॉइंट वाज ओनली दिस प्लीज.
चलें सर, अगला सिनेरियो पूछें, बस इस पे डिस्कशन ये हो गई है.
मेरे ये दो थे. Anyone else, please?
Lifelong, he mentioned about the lifelong PPI. So I'm not in big. This is I think hearing for the first time. So lifelong PPI. Lifelong. You mentioned about the you need to prescribe the lifelong PPI of for this patient.
Yes sir.
रिकमेंडेशन क्या है?
सर रिकमेंडेशन यही है कि लाइफ लॉन्ग पीपीआई जो है ना आप दे सकते, परफोरेशन के साथ प्रेजेंट करते हैं या ब्लीडिंग के साथ इस तरह से प्रेजेंट करते हैं.
अच्छा, no, but I'm not sure if you have evidence. If you can,
नहीं, I also
appreciate if you can share that.
Sorry.
Evidence.
सर ये मैं आपको अभी इससे पहले से ही बताऊं.
ठीक है.
नहीं, मेरे ख्याल से आमिर ठीक है इसमें. आमिर अब ये एंडोस्कोपी भी करानी होती है आपने वंस यू हैव रिपेयर्ड परफोरेटेड ड्यूडेनल अल्सर
बाद में?
आफ्टर दैट, हाँ बाद में.
जी सर, फॉलो अप तो आप कर सकते हैं.
हीलिंग के लिए
नहीं कर सकते हैं या करनी है?
ये वैसे नहीं मैंने पढ़ी कि करनी है कि नहीं करनी है.
वैसे यहाँ कभी
क्यों मकसूद?
सर मैंने अब एग्जैक्टली आई एम नॉट श्योर. मेरे ख्याल से इसका फॉलो अप में अब ये एंडोस्कोपी भी है क्योंकि कोई अल्सर ना हो या कोई जिस तरह ये कह रहा था बायोप्सी आपने अगर लेनी है तो वो भी तभी ली जा सकती है.
जी सर, वो
राइट से आप राइट. अच्छा चलिए जी. So let's move on to the third scenario. So who is going to become an examiner for the third scenario?
Sir, I will do. और आप करेंगे?
If you want to do, okay, go ahead.
नहीं आप बता दें जैसे आप कंफर्टेबल हैं.
I am comfortable.
ओके ओके. आमिर आपने वो देख लिया है, वो कुछ शेयर कर रहा था सर पहले उसको.
सर मैं वो बाद में कर देता हूँ.
बाद में कर लेंगे.
अच्छा ठीक है. ओके फाइन. Okay. Amir, a 45 years old female who had laparoscopic cholecystectomy 7 years back. She presents to ER with colicky abdominal pain in epigastrium and right hypochondrium. She had one episode of vomiting. Her vital signs are stable and she is not jaundiced. How will you proceed?
And this is a middle-aged lady with upper abdominal pain. She had previous biliary surgery. I would be suspecting some sort of biliary injury in this case. Moreover, I would keep in view, I would rule out pancreatitis, peptic ulcer disease, hepatitis, pyelonephritis, as well as amoebic liver abscess and hydrated cyst disease in this patient.
Okay,
In
well,
order to
what investigation you will advise?
apart from the baselines, I would request serum lipase,
That
LFTs,
is normal.
and
Normal.
ultrasound abdomen.
Okay, on ultrasound, you find that there is a simple cyst in right lobe of liver, and there is a stone in cystic duct stump.
There is a cystic duct stump. There is a stone in the cystic duct stump, and there is a simple cyst. I would like to know what's the size of the uh, cyst and on ultrasound, and
Well,
where is it
cyst
exactly located?
is 2 by 2 centimeter, and a stone is 1 centimeter.
So it's a big stone in the cystic duct stump. So that's mainly causing the symptoms. The size of the cyst is not that large to cause symptom. However, I would obtain triple phase contrast enhanced CT scan in order to confirm that the cyst is benign, and I would also request alpha fetoprotein.
Okay,
Moreover, I would request
CT scan
MRCP in this.
confirms the finding of ultrasound about simple cyst, and it reveals that it also confirms the finding about the cystic duct stump stone. How will you proceed?
So this patient requires removal of. I would like to know what's the length of the cystic duct stump. Is it?
It is 1 centimeter.
It's 1 centimeter. So it's pretty close to the CBD junction. In this case, I would go for. I would involve hepatobiliary surgeon with me, and I would go for cystic duct exploration, and I would removal of the stone followed by flush ligation of the cystic duct stump.
Okay. Any other investigation you would like to do before exploration?
Yes, before exploration, I said that I would go for MRCP in order to rule out any stones in the common bile duct.
Okay. And will you do it by open surgery or by laparoscopic surgery?
I would initially begin with laparoscopic surgery, depending upon the availability of the.
How will you place your ports?
I would place the ports in the usual manner for cholecystectomy, and I would place another port for retraction of the liver in the right hypochondrium, and the port that is placed for gallbladder retraction, I would place it higher up to retract the liver, and then I would explore the cystic duct stump and clip it close to the CBD and remove the stone by placing in the bag.
Right. You performed the surgery, patient became fine, but after 5 days, she presented with pain in right hypochondrium and fever.
So it was a recurrent surgery. I would be suspecting any bleed or biliary leak in this case.
How will you confirm it?
I would confirm it with the ultrasound abdomen.
Okay, on ultrasound, there is collection in subhepatic area.
I would like to know the size of the collection, how big it is.
Well, it is 8 by 10 centimeter in size.
So this is a large correction and it requires drainage. I would request my radiology colleague to put in a drain.
Well,
At the
he
same
put in
time,
a drain and there is persistent leak for many days from the drain.
I would repeat MRCP in this case.
MRCP
and,
reveals that there is again leak from cystic duct stump.
then I would involve my gastroenterology colleague and I would request him to place a stent at the
Okay.
cystic duct stump site
He
so
placed the
that the leakage
stent
can be minimized.
and patient became fine. There was no leak from the drain. When will you remove the stent?
Sir, in this case, I would keep the stent for 6 to 8 weeks, and then I would re-examine and along with my gastroenterology colleague, and then remove the stent.
Okay, fine. Very good. Thank you.
Thank you, sir.
Okay.
तो बस इसमें आपने एक MRCP थोड़ा जो है ना एक्सप्लोर करने से पहले जो है वो उसका जिक्र
वो
आपने
थोड़ा
जरूर
सा
किया।
पहले मैंने जिक्र किया, लेकिन बड़ा हल्का सा किया, जोर से करना चाहिए था उसका जिक्र।
आपने एनाटमी डिफाइन करनी है एक्सप्लोरेशन से पहले।
जी सर,
तो
एनाटमी है पॉइंट।
सर मिजान, आपकी तरफ से फीडबैक कोई?
Masood, I have a question.
Yes,
So
sir.
this is the case of retained cystic
सर
duct
सर आवाज आपकी बहुत तंग कर रही है।
okay. Cystic duct stump stone. So because if you redo surgery, difficult surgery. So why not, if we can say if redo surgery? So I will discuss with the hepatobiliary surgeon and refer this patient to the hepatobiliary surgeon. Because it's elective.
Yes.
It's not an emergency. So
why not?
the
Yes.
dissection at this 1 centimeter of cystic duct is very difficult. It's very likely that if I may injure the common bile duct, a lot of adherence. So unless the examiner asks you, okay, if the hepatobiliary surgeon is not available, then what will you do?
To begin with, this was a
I will
case
say,
for a
I will send
hepatobiliary
because
surgeon.
it's elective. I will just give him the analgesia. I will, if there's an evidence of infection, I will.
इसने मेरे ख्याल से जिक्र किया है सर बीच में hepatobiliary surgeon का।
Involved.
अच्छा मुझे नहीं
involved.
ठीक है।
He involved the hepatobiliary surgeon, but I'm saying that I will do.
It's a primary case for him.
I will send the patient to hepatobiliary surgeon for the redo surgery. And similarly, while putting the ports, so you need to be careful that previous port sites there could be, and although there is very less chances of adherence, so you need to be careful that there might be bowel or something which is adherent underneath these port sites.
अच्छा दूसरा about the ports, he said that I will place the usual cholecystectomy ports. I think it's better कि अगर examiner आपसे पूछ रहा है how would you do the lab खोलिए तो फिर आप बताएं उसको steps में कि कौन सी ports आप रखेंगे।
ठीक होगा सर, सही है।
प्रेफरेबली सर मैं अगर मेरे से पूछा जाए ना तो मैं तो अगर पहले से वो इंफ्राअम्बिलिकल गया हुआ है तो आप सुप्राअम्बिलिकल चले जाएं, थोड़ा चेंज कर लें तो ज्यादा बेहतर होगा।
Yeah, so because there are chances of adhesion. Although in the laparoscopy there are very less chances of adherence, but yes, there is small chances after the port because there's port placement. So going to the same port, the first port is very important. So in this case, if you ask me, if I have to redo surgery, so I will go through the Palmer's point.
आमिर, इसके पामर पॉइंट के अलावा भी कोई अगर मतलब वो उसका नीमोपेरिटोनियम का और भी कोई तरीका है?
जी सर, ये जो है ना हमें सर ने याद कराए हैं।
हाँ बताओ ना।
सर एक है लीहान्स पॉइंट है और दूसरा जो है
Jane's.
well, there is a point in the epigastrium and there is a point at the lateral border of the rectus at the level of the umbilicus.
Semilunar. Jane's point, Palmer's point,
Jane's और लीहान।
हाँ,
जेम्स और लीहान, जेम्स और लीहान।
यार ये जरा लिख के भेज देना, ये बाकी दोनों लिख के भेज।
Okay. Right. So any
इसमें सर तीन है। एक तो ये जो मिड क्लेविकुलर लाइन है ना, इसमें इस लेफ्ट साइड पे अराउंड 2 सेंटीमीटर बिलो कोस्टल मार्जिन ये बन जाता है इसका पामर्स पॉइंट। तो ये जो है एक पॉइंट है। फिर उसके बाद दूसरा है ये अम्बलाइकस में और इसके दरमियान जो है लीहान पॉइंट है, और जो नीचे है ये अम्बलाइकस के लेटरली सेमिल्यूनर लाइन के साथ ये बन जाता है, लिनिया सेमिलुनरस के साथ ये जेम्स पॉइंट है। ऐसा ही है ना सर शफाकत?
हाँ बिल्कुल बिल्कुल, you're right. Okay.
इस केस में पालर पॉइंट की जरूरत नहीं है यार।
Okay,
जी सर, इसमें एपिगैस्ट्रिक पोर्ट से भी पहले कैमरा डाल सकते हैं क्योंकि वहां पे एडेजेंस के चांसेस कम है।
कम है।
ये विजी पोर्ट के साथ जा सकते हैं
फिर
Yes.
जो है अभी पता नहीं, मैं देख रहा था, वो पता नहीं किस हद तक वैलिड है। वो लोग तो वो यूट्रस के थ्रू
Yes. Transvaginally we can.
करते हैं।
Yes.
देखो,
Yeah. Right.
हाँ,
Yes. In female patient.
सर
Okay.
इम्तिहान पास करना है, मुकदमा नहीं बढ़ाना।
Okay. You need to be careful that the session is being recorded.
जो है ट्रांसवेजाइनल और इवन थ्रू द रेक्टम भी वो करते हैं, लेकिन ये इतनी वो नहीं हो रही,
सक्सेसफुल नहीं
आप कह
होती,
लें
सही
कि
है।
इन नहीं हो रही। वजह यह है कि इसमें आप एक विसरा को ब्रीच करके जाते हैं, तो उसमें चांसेस हैं फिर लीकेज शीकेज के, और
Okay.
इस वजह से।
Amir, I think if no one has further questions, so let's move to scenario number 4. I think that would be
सर
last one. Can you hear me?
यस सर।
Okay. So this will last scenario. Uh, okay. You have received a call from the emergency department. So in the 8-year girl has been brought in the emergency department, and they have performed the chest X-ray with the suspicion of the foreign body ingestion. So I'm going to show you the X-ray. That this X-ray has been shared to you. So let me show you the X-ray. Now, is my screen visible?
यस
Okay, this is the X-ray which your ER physician they have performed. So what will you do? It's an 8-year girl. She has been brought in the emergency department.
what she has done, she has ingested this coin, or she has
Yeah, they were suspecting there's a foreign body ingestion, so that's why they performed this chest X-ray, and this chest X-ray has been shared with you.
in this case, this is a child with foreign body ingestion, and the coin appears to stuck in the mid chest. I would be worried about airway obstruction and signs of respiratory distress.
Okay, there is no
I would
signs
like to
of
know
airway
that whether
obstruction.
there are signs of respiratory distress or not.
No, there are no signs of airway obstruction or respiratory distress.
So this X-ray, this coin most probably is in the esophagus. Then it's at the level of gastroesophageal junction or lower esophagus, and
What will you do?
rather at the level of the mid esophagus, where it crosses the trachea, and there is a constriction over there, and the coin is stuck over there.
What will you do? What will be your next step?
Sir, my next step would be to send full blood counts, keep the child NPO, and involve upper GI gastroenterology colleague. The treatment is removal of the foreign body by performing a flexible endoscopy.
Why do you want to remove this coin? This foreign body?
Because it's stuck in the mid chest at the level of at the middle constriction of the esophagus, and it's
So
the
how do you
size
know
of the
that it
coin
hasn't stuck?
appears.
So how do you know that it hasn't stuck?
Because it's at the level of the bronchus, where there is a
So
constriction, and
would you like
most
to?
probably it's not going to pass forward.
Okay.
And there is a possibility that if the child vomits or aspirates this coin.
Okay. So what is the percentage of the foreign body that used to pass spontaneously? What is the percentage?
Sir, I'm not sure about the percentage, but these rounded, smooth foreign bodies, they can pass spontaneously. But if they appear large and they are stuck, then they must be removed.
So okay, then they must be. But for that matter, you need to repeat the X-ray. So yes, it's moving or not.
Moreover, in this case, there is a the vague history. This is a rounded foreign body. It might be some
Okay.
battery or something else.
Okay. Okay. Then what will you do?
Sir, I would prepare this patient for emergency endoscopy, and
Okay.
I would, along with the gastroenterology colleague, I would remove this coin.
Okay. Okay. Fine. Now they have removed this one. Uh, Coin, and let me show you another this one. So after the removal, what will like to ask from the gastroenterologist? They have removed it. They have removed it.
Sir.
Yes.
They have removed the coin, and
yeah.
Then I would
what
like
information would you like to? What information you like to have from the gastroenterologist?
I would like to ask him that whether there were any erosions, what was the condition of the esophagus, was there any difficulty while removing, was there any iatrogenic injury during the course of the removal?
Okay, it was a lithium battery. Lithium battery. Now there is a mucosal, there is evidence of mucosal injury. Your gastroenterologist has conveyed it to you. There's ulceration of mucosa.
So it's a mucosal injury. So in this case, I would request gastroenterologist to place NG and advance it to the duodenum, so that I would keep give rest to the esophagus, and I would at the same time continue oral feeding. I would admit the child in the high dependency unit, observe her for any signs of uh, uh, respiratory distress or chest pain. I would perform chest x-rays in order to rule out any full thickness perforation.
Okay.
Or and at the same time, I would give her antibiotics, analgesics.
Okay, on third day, on third day of admissions, patient has vomited, and vomiters contain small amount of blood. What will be your next step?
If the blood amount of the blood is small, I would review her medications. I would see that she is not receiving any anticoagulating coagulation. She is not on any anticoagulatory drugs. That might be generally.
She's not taking any anticoagulant.
Pardon?
She is 8-year-old. She is not taking any anticoagulant.
Okay, then my first suspicion would be stress ulceration, or
what will you do?
Progression of the caustic ulceration would be the first thing, and the second would be stress ulceration. I would give sucralfate and PPIs in this case.
Okay, you have started with the sucralfate and PPI. So after on the second day, during ward rounds, you notice that the patient has started. She had a massive episode of hematemesis. Or what will you do?
Now I would re-involve my gastroenterology colleague, and I would ask him to perform a gentle endoscopy, and I would evaluate the esophagus and stomach, and I would like to look for any perforation or any frank ulceration or any progression of the initially mucosal breach caused by the caustic agent.
Let me give a, let's go back. Once this patient presented the ER, so chest X-ray was repeated after 6 hours. This coin was located. This was found in the stomach. So does it changes your management plan?
Yes. Once this patient, the coin is in the stomach, then it can most probably pass simultaneously. But if it is battery, then it would not. But if it is a coin, then I would just observe her conservatively. But since she ingested a battery, then we will remove with gastroscopy.
Okay, you have waited because the patient was asymptomatic and you continue with the conservative treatment. So on the second day, this foreign body was found in the ileum, distal ileum. What will you do?
I would wait again because it would take around 4 to 5 days. 3 to 5 days is the normal transit time. So I would wait for another day and I would do serial X-rays. Most probably the coin would pass by itself.
Okay, thank you.
यार इसमें अपना शफाकत
Sir?
जब इसमें तूने ये वो जो इसोफेजल परफोरेशन करवाई है तो उसमें तो आइडियल ये बेरियम थिन बेरियम स्वालो से नहीं हम डायग्नोज करते उसको
No. When you are suspecting esophageal perforation, so barium swallow is contraindicated.
गैस्ट्रोग्राफिन सर देना है वाटर सॉल्युबल कंट्रास्ट का नाम लें इधर अगर लेना है तो
सॉरी
किसी का भी नाम ना लें
सॉरी बेरियम कह रहा हूं
Okay,
गैस्ट्रोग्राफिन
so any questions if you want to ask, then we will continue with this scenario.
Well, Amir, why
dissection.
do you want to remove the lithium battery from stomach?
Sir, because it's associated with the caustic injury to
But
the
I
mucosa.
think it is in esophagus, not stomach. Once it is inside stomach, it can pass through.
It can cause sir, the risk with the lithium injury is the battery is that it can release acidic contents that can cause mucosal ulceration wherever it is.
That injury is more common in esophagus. Once it has passed the esophagus, it usually passes down.
सर ये मेरा ख्याल है कि इसमें लिथियम में बैटरी
यार
का जहाँ
इसका
पे
ना
भी है
एल्गोरिदम है इसका एल्गोरिदम है मेरे ख्याल से ना एसोफेगस में ज्यादा है सर शफाकत ये इस पे जरा रोशनी डालें ना स्टोमक में हो तो मेरे ख्याल से पास हो जाती
lithium
है
battery it has to be removed.
Okay. So if the battery is the lithium battery is lying inside the stomach. So you need to know what is the size of this battery, what is the age of the patient, is there any symptoms? So the patient, this foreign body is the battery is moving or not. So if the patient is asymptomatic, the battery size is less than 15 millimeter, 1.5 centimeter, and it's stuck for more than 4 days. Size more than 15 millimeter, 1.5 centimeter, and it's not moving for the 4 days. If the patient is developing symptoms related to the perforation, any abdominal symptom, that is an indication for the removal of the battery. But if the size is, for example, 2 centimeters, so obviously with this big size, it would have stuck inside the esophagus. You need to know, you need to get the upper GI endoscopy to see the extent of the esophageal injury as well, in addition to the removal of the foreign body from the stomach. But if it has gone beyond the stomach, so then it will most likely pass. But you need to know, you need to monitor the patient. The patient is developing any symptoms related to the perforation. In that case, you have to intervene. So starting from the scenario, so I gave you the scenario. You can ask a few questions during the history. So what is the duration? Because in case of lithium battery, the emergent endoscopy is required. That should be done within 2 hours. So you need to ask me the duration. When was this when was this foreign body ingested? Then the size of the battery. Are there any associated symptoms? Are there any symptoms related to the perforation? Whether this the battery has got perforation, the patient has already presented in the perforation with the perforation. Patient is having chest pain, patient has sepsis. So that means they have already caused the perforation. So you asked me whether there are any airway signs of airway obstruction, respiratory distress. So then the chest X-ray you need to get in the lateral view as well. You need to know where is the negative terminal. So is how to differentiate the coin and the battery. So with the help of you ask your radiologist, I am suspecting the battery in this patient. So that will, they give you the hint that there's a double halo, there's a halo sign, double ring sign. And then in the lateral view, you need to know where is the negative terminal. So that side, it causes most of the damage. So then the next investigation is to get the contrast and CT scan to know the extent of the damage. So in case of if it's a battery, so the emergent endoscopy is required, emergent within 2 hours. And while preparing the patient for the endoscopy, you can give them honey, you can give them sucralfate. Otherwise, you need to keep the patient NPO, nil per oral.
हनी भी दे सकते हैं, लेकिन वो तो फिर आपने एंडोस्कोपी करनी है.
No, so इस केस में देंगे. When you have suspecting there's a battery, right? Why will you give the honey? Honey actually it coats the battery and it delays the release of the content from the battery. Similarly, sucralfate actually it coats the battery. So that is why the recommendation to give the honey. So 10 ml, you can repeat it after every 10 minutes. But if the patient has ingested the battery within 12 hours, if it's more than 12 hours, then you will not give the honey or sucralfate because there is a risk of the perforation. Now, once there is an esophageal injury, so that is you asked me whether there are any mucosal injury or not. If there is a mucosal injury, then next step is to refer the patient to the tertiary care center because these patients may develop complications. For example, these patients may develop esophageal aortic fistula. They may develop tracheoesophageal fistula. They may develop the cervical discitis. They may develop recurrent laryngeal palsy. There are so many complications, and the patient needs frequent assessment with the help of the clinical examination, urological contrast and CT scan, and endoscopy to just see whether the patient is developing some complication. But in this patient, the patient developed sentinel bleed initially. So at that was the time you need to involve your cardiovascular team or endovascular need. Then ultimately the patient will end up with upper GI. So that risk continue for at least 4 weeks. So you need to keep in mind here, this with a mucosal injury, patient can end up with the complication even after 4-5 weeks.
इसमें स्ट्रक्चर भी बन सकता है later on.
हाँ, yeah.
फिक्सिंग हो सकती है.
Yeah.
हो सकती है बिल्कुल.
आपने
शुरू कॉइन से किया, फिर आप बैटरी पे चले गए. मैंने कहा शुरू आपने कॉइन से किया था 6 घंटे की हिस्ट्री के साथ.
Okay, I show the. Okay, I show this algorithm. Let me show you.
हाँ, ये शो करना सर.
Let me show you.
एक दफा पहले भी मेरे ख्याल वो उस पे भी डिस्कस हुआ है, सर्जन फोरम पे भी 1-2 दफा डिस्कशन हुई है.
सर ये इस पे शेयर कर दीजिएगा, ग्रुप पे शेयर कर दीजिएगा.
उस पे मैं कर देता हूँ. Let me share it with you. Can you see my slide share? Algorithm, is it visible or not?
The file explorer is visible. No algorithm is visible. No. Open नहीं हुआ.
नहीं हुआ. अच्छा. Okay, let me go back again. Stop share. अब आप देखिए आपके आ रहा है सर इस पे, ये वर्ड की फाइल है.
नहीं, ये नजर आ रहा है कि वर्ड की फाइल है, लेकिन खुली हुई फाइल नजर नहीं आ रही.
अभी खुल गई होगी ना. अभी नहीं खुली.
नहीं,
अभी नहीं आ रहा है सामने आपके.
नहीं, स्क्रीन वही नजर आ रही है, फाइल एक्सप्लोरर खुला हुआ है.
अच्छा, चलिए मैं उसको शेयर कर देता हूँ. ग्रुप में शेयर कर देता हूँ. तो आप इफ यू वांट टू ऐड समथिंग सर.
नहीं, शुरू में मैं भी ये इसी चीज से कंफ्यूज हुआ था कि मेरे ख्याल में अगर चीज क्लियर नहीं है या हिस्ट्री वेग है तो फिर ये एग्जामिनर को बताना चाहिए कैंडिडेट को कि जी मैं कंसर्न हूं कि whether it's a coin or a battery.
So I think
और पहली चीज एंड सेकंड इज मैं वही सोच रहा था जो बाद में तुमने एंड पे कहा, एंड पे वो आ गए थे कि लैटरल व्यू एक्सरे होना चाहिए कि नहीं होना चाहिए, क्या वो सिर्फ ये कंफर्म करने के लिए होना चाहिए कि ये बैटरी का नेगेटिव एंड किस साइड के ऊपर है, या अदरवाइज भी इस तरह के केस में लैटरल व्यू होगा?
because you need to know whether it's lying in the asymmetrical side or symmetrical.
तो होगा ना, मतलब
हाँ,
लैटरल
lateral
व्यू
view must,
एक्सरे तो हमें वैसे ही कराना है ना,
lateral view the must. और
whether
इसमें
it's a battery or not a battery. जब हमारे पास हिस्ट्री पेज है, so we don't know whether it's an esophagus or in trachea.
या तो
ठीक है,
हाँ, इसमें इसमें जो करना ये है कि ये देखना है जो जब भी कॉइन आएगा आपके पास, तो कॉइन में हमेशा सस्पेंशन की बैटरी नहीं है, उसमें मैग्नीफाई करके तो बैटरी इज एन इमरजेंसी, सो यू नीड टू टेक इट आउट. तो और उसमें जस्ट लुक लाइक सेम एज इट्स अ कॉइन, वो लगेगा आपको इसी तरह ही. तो ये हमारे पास शिफा में इस तरह पेशेंट था, बच्चा था, वो इस तरह आया सर इंजेक्शन के साथ, उनको कॉइन के साथ करते रहे उसके साथ. इट्स बीइंग रिकॉर्डेड. ओके चलो यानी वो बाद में शेयर करूंगा जब, तो मैं पॉज कर देता हूँ. What are the foreign body which you cannot pick on the X-rays? For example, fish bones, which X-ray has very low sensitivity, 32% sensitivity. Fish bone, bolus obstruction, you cannot pick it on that. Similarly, plastic, wood objects, you cannot pick it on the X-rays. उस सूरत में अपने क्या करें? You need to get a contrast and CT scan. So it's very important. और फिर जब मैं whenever there is a history, yes, there might be history of ingestion, you take it very seriously. Otherwise, about 90% of the patient, the foreign body used to pass spontaneously.
सही.
So,
आमिर आप कुछ कह रहे थे?
हाँ सर, मैं इसका वही कह रहा था, मैंने कहा तो मुझे ये था कि सर ने अब कहा कि जी वेक हिस्ट्री ऑफ इंजेक्शन है, तो सर इसको रेस्पिरेटरी डिस्ट्रेस पे ना ले जाए, तो मैंने वो वाली साइड तो कवर की. फिर अब ये
अच्छा
बीच
बिल्कुल हो
में
सकता है, हाँ,
वो
अच्छा किया कवर करके.
बाकी ये वाला चीजें थोड़ी सी और डिटेल में मुझे सर से एक्सप्लोर करनी चाहिए थी.
क्योंकि
लेकिन
अगर
फिर
आप
वो
ये
यही है कि
इनिशियली
ज्यादा सवाल पूछ के एग्जामिनर यही ना कहे कि भजन वाइवा ताड़ा है, मेरा नहीं हैगा.
तो बहुत ज्यादा ना पूछे ना, लेकिन आपको आपका ये सवाल पूछना भी एग्जामिनर को यही बताता था यू आर कंसर्न्ड अबाउट दीज पॉइंट्स, आपके जहन में ये चीजें चल रही हैं एट द मोमेंट. ये तो अच्छा मेरे ख्याल में एक साइन है
नहीं,
पूछना.
अच्छा सर बिल्कुल है, लेकिन
पूछे,
वो
लेकिन
दैट
पूछ ही जाना नहीं
डिपेंड्स
ठीक ना.
एग्जामिनर टू एग्जामिनर. ये ना हो कि वो इरिटेट हो
हाँ,
जाए. बस आपने
मैं वही कह
एग्जाम
रहा हूँ,
पास करना है.
पूछना ठीक है,
हाँ
पूछना ठीक है, पूछ ही जाना नहीं ठीक.
you need to see that the body language of the examiner is
यस.
he irritated or not. So उसके साथ आप उसको देख के मॉडिफाई कर दो. कहते बार बार कहते नहीं, डोंट आस्क मी द क्वेश्चन, आपको उसकी बॉडी लैंग्वेज से पता चल जाएगा.
अगर तो मान गई तो ठीक है, नहीं तो बाजी डर गई.
ठीक है. So you perform very well. You perform very well throughout the all the scenarios. You remain composed and answer the question very satisfactorily. Although there is always a room for
कॉन्फिडेंस मेंटेन रखना है और कंपोज रहना है बस.
So you did very well today.
उसका उस्मान का नहीं है अभी सिनेरियो कोई?
I think it's
उस्मान म्यूटेड है,
15 minutes.
उस्मान आवाज नहीं आ रही.
पौने 11 हो गए हैं
सर. मैंने कहा मैं जो है ना आज वैसे भी बना नहीं सका क्योंकि मैं अभी कॉल